Guidelines for antibiotic use in abdominal surgery focus on reducing the risk of surgical site infections, SSIs, while avoiding overuse that could lead to resistance or adverse effects. Here's an in-depth breakdown based on current standards. 1. Preoperative antibiotic prophylaxis. Timing, administration. Antibiotics should be given within 60 minutes prior to the incision, or 120 minutes for drugs like vancomycin or fluoroquinolones with longer infusion times. This ensures optimal tissue concentrations during the critical time of potential contamination. Selection. First-line agents. Cefazolin covers most common skin flora, e.g. Staphylococcus aureus, Streptococcus species, and some gram-negative organisms. Cefoxitin or cefotetin, preferred for cases involving anaerobic bacteria, e.g. colorectal surgery. Alternatives for beta-lactam allergy, clindamycin or vancomycin for gram-positive coverage, combined with gentamicin, ciprofloxacin, or aztreonam for gram-negative coverage. Considerations for specific procedures. Clean surgeries, e.g. hernia repair without mesh, prophylaxis not routinely required unless there are risk factors like immunosuppression. Clean contaminated surgeries, e.g. gastric, small intestine, biliary tract, or colorectal surgeries. Antibiotics targeting both gram-positive and gram-negative pathogens, often including anaerobes for colorectal procedures. Contaminated or dirty surgeries, e.g. perforation or peritonitis, therapeutic rather than prophylactic antibiotics are used. Redosing. Redose antibiotics intraoperatively if the procedure exceeds 2 half-lives of the drug. There is significant blood loss, 1,500 milliliters. 2. Intraoperative antibiotics. Prophylactic antibiotics are not extended intraoperatively unless redosing criteria are met. Adjunctive therapies. For contaminated, dirty cases, use therapeutic antibiotics guided by culture data. Postoperative antibiotic use. Prophylaxis. Not routinely required beyond the intraoperative period for clean or clean contaminated procedures if no gross contamination occurs. Prolonged use increases risks of resistance and complications like Clostridioides difficile infection. Therapeutic use. In cases with established infections, e.g. intra-abdominal abscess peritonitis, therapy is guided by microbiological results. Initial empiric therapy often includes piperacillin tazobactam or ceftriaxone metronidazole or acarbapinem for extended-spectrum beta-lactamase, ESBL pathogens. Duration. Typically 4 to 7 days, shortened with source control, e.g. adequate drainage. 4. Antibiotic stewardship. Routine practices include de-escalation based on culture results, avoiding unnecessary broad-spectrum antibiotics to minimize resistance, utilizing local antibiograms for selecting empiric therapies. 5. Special populations and considerations. Biliary surgery. Antibiotics are indicated if bile is infected or the patient has risk factors, e.g. jaundice, recent cholangitis. Recommended cefazolin or ceftriaxone. Appendectomy. Simple appendicitis, single dose preoperatively. Complicated appendicitis, postoperative antibiotics for up to 4 days if the infection is controlled. Colorectal surgery, mechanical bowel preparation with oral antibiotics, e.g. neomycin and metronidazole, plus systemic antibiotics preoperatively. Trauma, coverage for open wounds or bowel perforation includes empiric broad-spectrum therapy. Emerging trends. Increased focus on reducing antibiotic overuse by adhering to duration guidelines. Use of intraoperative point-of-care diagnostics to tailor therapy. These recommendations should be tailored to local microbiological data, patient risk factors, and specific surgical contexts.